Mycobacterium tuberculosis is really primarily a human disease, and it's one that's associated with low socioeconomic status. It's one of the leading causes of death in low and middle income countries. So this is some data from the World Health Organization documenting the top 10 causes of death in this particular figure in 2019. And what you can see is that tuberculosis was number 8. Now, fortunately, some advances have been made in combating tuberculosis deaths. So you can see here, the rate was lower in 2019 than it was in 2020, but still the burden of communicable illnesses is quite high. If we compare this to high-income countries, you'll see that tuberculosis does not even make the list. So this is really a disease that we associate with under-resourced systems and poverty. Here in Canada, on the left in this figure, you can see the rate of tuberculosis in Canada over time. So this is number of cases per 100,000 population on the y-axis, and it goes from 1924 all the way up to 2021. I think you can appreciate there's been quite a steady decline in the incidence of tuberculosis infections in Canadians. The exception is the rate of tuberculosis among our Indigenous communities, which is unacceptably high compared to the rest of the population. So in this figure here from the Public Health Agency of Canada, you can see that among the Inuit, we have a rate of 135 cases per 100,000 people. In other First Nations people, non-Inuit across the country, 16.1 per 100,000, and among Métis, 2.1. If we look at non-Indigenous people born in Canada, it's 0.3 per 100,000. So comparing to Inuit, it's about 500 times less common. This disparity reflects a long history of injustices and the legacy of colonialism in Canada. Moving on from our Mycobacterium tuberculosis group to Mycobacterium avium subspecies paratuberculosis, which I'm just going to call MAP from now on. This is the agent of Johne's disease. And in our ruminants, we see it as a cause of chronic contagious granulomatous enteritis. In affected animals, we see persistent diarrhea, weight loss, debilitation, although animals are not, generally speaking, febrile or really depressed. 50% of animals who have Johne's disease can be subclinical, so we don't recognize any outward signs of illness in them. And the pathology is associated with thickening of the distal small intestine. That's really the characteristic lesion, and results in emaciation and poor absorption of nutrients. You can see this Holstein cow here, affected with Johne's disease, is emaciated, which is frequently what's seen. This is a slowly progressive disease. It takes months to years to develop, and as a consequence of this, we don't see clinical signs in animals that are under 2 years old. It also causes disease in other ruminants, so we see it in sheep and goats. You can see a very emaciated goat in this image on the right. And Johne's disease has a worldwide distribution, including here in Canada. Unfortunately, we don't have any treatment options or any vaccines, so it really relies on management strategies such as culling carrier animals. In these images here, you can see the lesions associated with MAP infections in ruminants. So on the left, we have some bovine ileum. This is normal ileum on the top and affected ileum on the bottom. And I think what really stands out is just how thickened and corrugated the mucosa is. On the right, we just have another cut section of ileum, again, with this very thickened and corrugated mucosa. This is an acid-fast stained smear from the gut of a sheep with Johne's disease. And again, I think what you can appreciate are these large numbers of acid-fast bacilli against a dark blue background. Next, we're going to talk about Mycobacterium lepromerium. This is the agent of feline leprosy. It's a chronic disease which is characterized by singular or multiple nodules, typically cutaneous nodules. And these occur most commonly on the head, neck, and forelimbs, although it can be anywhere on the body. We don't know a lot about the epidemiology of this infection, although it does seem to be more common in coastal areas. This is a right stain of a sample from a cat's mouth, and what you can see here are all of these macrophages and these little ghostly bacilli structures. These are the organisms which don't take up the stain because of that mycolic acid. Treatment of these infections relies really on surgical excision, so you physically remove the masses, combined with adjunctive antimicrobials. The Journal of Feline Medicine and Surgery had this fantastic case series that I would strongly recommend checking out. And in these images on the right, you can see some lesions which were atypical in their distribution, but sort of match what we see with Mycobacterium lepromerium generally. So these large soft tissue lesions in various anatomical locations. Here we have on the tongue. It can also be on the face and forelimbs. Mycobacterium leprae is the cause of leprosy in people. This is a slowly progressing disease of the skin, peripheral nerves, eyes, and upper respiratory tract. And it's a disease where those who are affected have historically been ostracized. Interestingly, it's thought that there's a really important genetic predisposition which allows people to become infected with Mycobacterium leprae, and only about 5% of people are actually susceptible. According to the World Health Organization, there were over 200,000 cases of this disease in 2018. So while it certainly has a high profile historically, it's by no means eradicated. This is a disease which is actually relatively easily treated with antimicrobials. In North and South America, human infections are primarily associated with armadillo contact. And this is true either in the southern United States and South America, particularly in Brazil. Here in Canada, leprosy is a reportable disease, and you can see the rate of infection, so the number per 100,000 population on the y-axis, from 1924 all the way up to 2021. You can see these numbers are quite small, and in 2021, the incidence of 0.02 per 100,000 equated to 6 cases in the entire country. So really not very common here in Canada. Beyond the Mycobacterium that we've talked about in detail, many other Mycobacterium species have been isolated from domestic animals and people. I want you to suspect these organisms when you're dealing with chronic granulomatous infections. Perhaps multiple rounds of antimicrobials have failed. Perhaps these are infections that you'll see in animals who are profoundly immunosuppressed, either iatrogenically because we've given them some immunosuppressive therapy, or maybe they have a primary immunodeficiency. When dealing with these infections, I would strongly encourage you to consult a specialist. Identifying Mycobacterium can be a challenge, particularly for these more unusual ones. And diagnostic labs need to use techniques like PCR and sequencing of phylogenetically informative genes in order to get a robust species-level ID. We have varying susceptibility between species within the genus, and so, like many of the unusual infections we deal with, I would strongly encourage you to consult with a good infectious disease textbook before treating. Just as one example to highlight the breadth of infections that we may see with Mycobacterium, in this image here, you can see a post-mortem exam of a chameleon, which had Mycobacterium-associated hepatitis, so all these little nodules in the liver. When collecting samples from animals where you suspect Mycobacterium bovis, personal protective equipment is required. You absolutely want to be wearing gloves and probably eye protection as well. Samples to collect include the lymph nodes and lung tissues, and then any other abnormal lesions which are identified. For Mycobacterium avium, subspecies paratuberculosis, feces, ileal lymph nodes, and blood can all be tested. And for Mycobacterium lepromerium from cats, tissue biopsies. We can identify cattle infected with Mycobacterium bovis through intradermal testing. It's important to know that we have false positives and that we actually get cross-reactivity with other Mycobacterium species. This is actually one of the reasons why we don't vaccinate. Diagnostically, using intradermal skin testing, it's impossible to differentiate vaccinated from infected. And this is clearly not practical in a country where we have a policy of eradication. False negatives can also occur. It's important that any of the reagents are handled appropriately and stored appropriately. And so for that reason, performing this testing requires a license from the Canadian Food Inspection Agency. MAP can be cultured. It's very, very, very slow. So in these two images here, we have some close-ups of MAP colonies. These little colonies on the left here, you can see they're just barely bigger than a millimeter, took 3 months to grow, while those on the right took 7 months to grow. So this is not a test that you expect results to come back within a couple of days. Because this test is so slow, other diagnostic strategies are really, really important, whether it's PCR, using special staining techniques like acid-fast on smears, serology, and also histology. Mycobacterium species should generally be considered to have a broad host range and should be considered zoonotic. Those organisms within the Mycobacterium tuberculosis complex should all be considered of highest risk, with M. bovis being the most relevant in North America. In fact, in the United States, Mycobacterium bovis is still responsible for approximately 2% of cases of tuberculosis in people. Transmission of M. bovis from cattle into people is through contaminated or unpasteurized dairy, and one of the big reasons that pasteurization is really, really important. We can also see people become infected when they have contact with infected tissues, dressing carcasses while hunting. So wild cervids, we know, are reservoir populations. There's speculation about the zoonotic potential of MAP as well, and possibly its association with Crohn's disease. To the best of my knowledge, Koch's postulates have not yet been fulfilled, so we don't yet have a causal relationship established. But there have been many studies done looking at antimycobacterial therapy for treating Crohn's patients. Mycobacterium avium is associated with infections in HIV patients, while Mycobacterium leprosy is really not considered to be zoonotic. Treatment options will really depend on what species you're dealing with. So for agricultural animals, antimicrobial therapy is not done. In companion animal species, polypharmacy is necessary to prevent the development of resistance. So we need to use combinations of antibiotics. Here, I would strongly recommend specialist consultation. We need a species level ID, and there's widely varying intrinsic resistance between species. So consult a good reference. Classically, susceptibility testing on Mycobacterium is done for the Mycobacterium tuberculosis complex, but this is really something that's limited to human infectious diseases and not widely available in veterinary medicine. We do see the emergence of drug-resistant tuberculosis as a big problem globally. Now, this is some data from the Public Health Agency of Canada. And what we can see is of all of the tuberculosis cases that were identified in, I believe, 2020, 1,563 of them, 1,538 were Mycobacterium tuberculosis complex, and the vast majority of those were susceptible to all drugs, which is great news. Monoresistance, so resistance to one drug, was found in 128. Polyresistance was found in 7. And multi-drug resistant TB, which is a very serious problem, was identified in 14. Fortunately, here in Canada, at least in this year of surveillance, no extensively drug-resistant TB was identified. This poses serious therapeutic challenges as there's already a limited number of drugs available which are effective against Mycobacterium. In the United States, the Centers for Disease Control publishes a list of our sort of greatest threats in antimicrobial resistance. And this infographic kind of highlights the impacts of drug-resistant TB in the United States. They estimate that each multi-drug resistant case costs $164,000 American to treat, while an extensively drug-resistant case, so these ones that we had none of in Canada, cost over $500,000 to treat. So not only is there a morbidity cost, a mortality cost, a human cost, but it is financially very, very difficult to deal with these multi-drug resistant organisms. No new terms today, but I do have a couple of questions for self-assessment.